This video discusses some of the philosophy and research behind what has become, more and more, my preferred approach for neuraxial blocks, the paramedian or paraspinous needle approach, rather than the more commonly taught and practiced midline or median approach. I'll be focusing mainly on lumbar neuraxial blocks, as in the thoracic spine, neuraxial blocks are always going to be paraspinous, even if you believe it's a midline approach that you're using. I firmly believe that the distinction between paraspinous and paramedian is an important one to make. When I was first taught paramedian approaches, both in lumbar and thoracic spine, I was often told to insert my needle a good finger breadth away from the midline spinous processes. And in some references, you'll still see instructions to insert the needle up to 2 centimeters away from the midline. And as a result of this, you end up having to adopt a large lateral to medial angle, which is where most of the problems arise. Triangulating the trajectory to enter the interlaminar space becomes more complex, and there are a lot more potential bony targets that you could be contacting. So logically speaking, it doesn't make a lot of sense, at least to me, because all we're trying to do with a paramedian approach is to avoid having to traverse the interspinous space and the midline interlaminar space, which can be narrowed by either inadequate positioning or degenerative disease. Now, this is my well-worn and annotated copy of a classic regional anesthesia textbook by Cousins and Breidenbach, and you can see that they advocate starting only 1 centimeter lateral to the spinous process. The authors specifically use the term paraspinous to emphasize that the needle just needs to slide in alongside the spinous process to reach the interlaminar space and vertebral canal. This allows us in turn to keep that lateral to medial angle very small, no more than 10 degrees usually, and this in turn simplifies the redirection process greatly. We don't have to calculate or vary that lateral to medial angle and can instead focus on incremental changes in just one axis of motion, which is to gradually walk our needle tip cranially along the lamina, which will lead us inevitably into the interlaminar space. And I'm going to use the term paraspinous rather than paramedian throughout this talk when I'm discussing needle insertion, just to emphasize this point. The merits of this paraspinous approach are no longer just anecdotal. There is scientific evidence for it. In this RCT, Chen and colleagues compared what they called modified and conventional paraspinous approaches to obstetric neuraxial blocks. The modified approach involved needle insertion 0.5 centimeters lateral to the midline and 0.5 centimeters caudal to the spinous process, versus 1 centimeter lateral and 1 centimeter caudal in the conventional approach. The practitioners in this study were second-year residents, and in teaching them to use the modified approach, the first attempt success rate was 2 to 3 times higher for all techniques, spinals, epidurals, and combined spinal epidurals. What's interesting is that there was also a much higher rate of complication-free epidural catheter insertion. The complications encompass dural puncture, difficulty threading the catheter into the space, and intravascular or intrathecal catheter placement. And this is something we'll return to. In another study, a group led by Miguel Reyna used MRI images to calculate the angles for successful paramedian needle entry into the vertebral canal. They note that conventional wisdom dictates an entry point 2 centimeters lateral, but they found that a closer insertion point 1 centimeter lateral was associated with a much wider range of angles that would allow success. And in addition, the variation in optimal angle with increasing depth was also less if you used the 1 centimeter insertion point. As this graph shows, over the commonly observed spinal and epidural needle depths of 4 to 8 centimeters in most adults, you see that the optimal angle for a 2 centimeter lateral insertion point spans a much larger range than the 1 centimeter lateral insertion point. And what this means, in other words, is that you can be confident that using a consistent single angle of about 10 degrees is going to be highly successful, regardless of the depth at which the space lies. Although, based on the graph, I would still say that for very large patients with very deep spaces, you should consider using an even smaller lateral to medial needle angle. But it's this fact that the paraspinous approach is more forgiving of imprecision that is the reason that I now often use it in obese patients. It goes without saying that ultrasound is very helpful and I always use it, But in really large patients, often all we can see is the midline shadow of the spinous processes, and I have to guess where the interlaminar space is. The problem is that even if I do mark the midline, if the subcutaneous tissues are very mobile, either because they are lax and loose, or if the patient is lateral rather than sitting, it's very difficult to keep your needle precisely in the neuraxial midline because of that tissue motion over the bony spine. And so, if and when you contact bone with your needle, it's hard to know if you're contacting the spinous process or the lamina on one side or the other, and thus where you should be directing your needle in the next pass, especially if you aren't controlling the skin and soft tissue with your fingers, which will further increase the imprecision of each needle pass. I therefore find it much easier to be deliberately paraspinous and aim to strike the bony lamina on that side, because then I know exactly where I am and where I have to go. I just have to keep walking my needle cranially until it slips into the interlaminar space. And basically what this is doing is simplifying my decision making for next steps, and thus also simplifying the whole process. Now, other studies have shown that paraspinous approaches have a higher success rate in patients with difficult spinal anatomy in terms of narrowed spaces. And this is because, as we've said, the paraspinous approach bypasses the narrow channel between those spinous processes. In addition, the paramedian interlaminar window generally has larger dimensions than the midline window and is thus an easier target to hit. In scoliosis patients, the paraspinous approach is particularly useful, and I discuss this in further detail in a couple of YouTube videos. But essentially, patients with scoliosis will have a larger window on the convex side of the curve, and this should be the side at which it's attempted. It's thus always worth examining the patient closely and reviewing lumbar spine imaging results where available. Ultrasound will also help identify which way the spine is curving and will also identify the rotation. Rotation is always present in scoliosis, and what it means is that a perpendicular needle insertion will actually be entering the paramedian interlaminar space. The rotation removes the need to have any lateral to medial angulation of the needle. Paraspinous approaches don't just make it easier to introduce the needle into the vertebral canal, it also increases the ease and success of epidural catheter insertion. Several studies have reported that catheters are easier to thread into the space and that paresthesias occur less often. In one cadaveric study using epiduroscopy, suggests that midline catheters tend to cause more dural tenting, and they're more likely thus to deviate laterally or even turn caudally, whereas paramedian catheters tend to travel cranially much more consistently. A couple of factors are thought to play a role in this. Posterior epidural ligaments in the epidural space, especially the dorsomedian ligament, may impede midline catheter advancement. And second, the steeper cranial angle of insertion that's usually employed with lumbar paramedian approaches versus the more perpendicular angle with midline approaches may help the epidural catheter to feed smoothly in a cranial direction, as seen here. But using the paraspinous approach doesn't just make neuraxial blocks technically easier. There are also significant patient-centered advantages. There's data from several studies that indicate that back pain is less common with the paraspinous approach versus the midline approach. And this one by Lee and colleagues was particularly compelling as they only included patients who had a single needle pass with a 25-gauge needle. I will say this finding was somewhat surprising to me, so I had always thought that pain from muscle trauma would be more significant. But in fact, it's thought that it's the trauma to supraspinous and interspinous ligaments caused by a midline approach that appears to be a more important factor, and certainly the evidence would support this. In addition, multiple studies, including this one by Singh and colleagues, have found a lower incidence of post-dural puncture headache with paramedian spinals versus midline approaches. It's postulated that the cranial angulation of the needle in a paramedian approach creates an angled and overlapping perforation of dura and arachnoid and perhaps even the flavum. And this may create a valvular flap that prevents or minimizes leakage. Miguel Reyna has published several articles investigating the trauma to dura with the spinal needles, and he's produced some wonderful electron microscopy images. Although the papers don't comment directly on this particular mechanism, I think the images are instructive in that they demonstrate multiple layers of tissue that are penetrated by the needle, and do lend some support to the fact that a valvular flap may indeed be created. So why isn't the paraspinous or paramedian technique more widely used despite these advantages? I think it's mainly because it's not as widely taught, which in turn is because it's perceived as harder to master. It does certainly require a more robust three-dimensional knowledge of spinal anatomy and the ability to mentally visualize where the needle is going. But like any technical skill in anesthesia or medicine, if there is proper instruction and you invest the time and effort to practice it, the paraspinous approach isn't that hard. I've guided many junior residents through successful paraspinous neuraxial blocks. Note that to be really versatile, you should practice it in both sitting and lateral positions, as the different orientation of the spine and your needle redirections can sometimes be confusing. Can we use ultrasound to help it make an easier technique? For sure, I think ultrasound imaging of the spine makes any neuraxial block easier, as it takes the guesswork out of the bony anatomy underneath the skin. And there are two methods we can use ultrasound to guide a paraspinous approach. Either a pre-procedural ultrasound-assisted approach or a real-time ultrasound-guided procedure in which you insert the needle under direct vision. We'll look at the pre-procedural ultrasound-assisted approach to start. And this is the approach that I would personally use in difficult patients. I follow a standard ultrasound scanning protocol, which is to start with a parasagittal oblique or PSO view. I identify the various intervertebral levels and mark their position on the skin. At the same time, I also assess the size of the paramedian interlaminar spaces, and this is a qualitative rather than quantitative assessment. My basic rule is if you can see an anterior complex, you have an open interlaminar space. And I consider it a large space partly on the spacing between adjacent laminae and the length of the visible anterior complex, but more so on how easy it is to obtain a view of the anterior complex in terms of how much probe manipulations I have to make. I then identify and mark the midline using the transverse midline view and either mark the intervertebral spaces or, if they are not visible, as in obese patients, I mark the spinous processes. I then perform the procedure as I would have done with a landmark-guided approach, inserting the needle no more than 0.5 to 1 centimeter lateral to the spinous process or the midline marked on the skin, and 0.5 to 1 centimeter chordate to the line that marks the interspace I'm interested in, or if I haven't been able to see the space, then I mark it cranial to the line marking the lower spinous process, as illustrated here. I then insert the needle at a lateral to medial angle of about 10 degrees as discussed. Now, I often start at a 5 to 10 degree cranial angle, but you could also choose to start with no cranial angulation, in which case you will inevitably land on lamina, and you can then creep up and into the space with redirections. Now, this is not actually how the pre-procedural ultrasound-assisted technique is described in most studies in the literature. Using this Korean paper as an example, we see that while most investigators also identify the paramedian intervertebral spaces with a PSO view, they then mark the middle of the short edge of the probe together with the middle of the long edge of the probe where the space is, and then they insert the needle at the intersection of these marks. There are two things to realize about this technique. First, it means that they are often attempting to access the interlaminar space without any cranial angulation of the needle. And this is fine when the space is large, but when the space is narrowed, you may find that the needle tip gets caught up on the lip of the lamina. Remember too that epidural catheters will feed more easily if the needle is angled cranially, so this may not be an ideal approach for lumbar epidurals. Second, the insertion point is also more lateral with a larger lateral to medial angle, and most investigators will admit that it requires memorizing the angle of probe direction and attempting to mimic that with the needle. This, however, requires more guesswork and estimation and thus is more prone to error. So I believe less experienced practitioners may find it difficult. I certainly do, and for these reasons, I don't do it this way. Nevertheless, this technique of pre-procedural ultrasound scanning and marking has still been shown to be more effective than a pure landmark-guided paramedian approach. Multiple studies have shown this, but I'll highlight just this one from Park and colleagues in Korea. They recruited only patients with either scoliosis or surgery, with the majority of them having scoliosis. All three practitioners were veteran consultant anesthetists with experience in both procedures, and what they found was that ultrasound pre-scanning resulted in fewer skin insertions and needle passes, as well as higher first attempt and first pass success rates. What about a real-time ultrasound-guided paraspinous approach? There's been a lot of work investigating this recently. With regard to thoracic epidurals, a very feasible technique was described first by Park and Gulati in 2018 and further developed by a Korean group who described their technique in detail in a couple of articles shown here. A parasagittal oblique view is again obtained of the thoracic vertebral interspace, with an important point being that the probe is angled slightly to avoid imaging the lower facet joint, which can sometimes present an obstacle to the needle trajectory. It's worth noting that this technique has so far only been described at lower thoracic levels, T9 to 10 or lower, where the spaces are wider than at the higher mid-thoracic level. Another important paper is this one by a Chinese group which conducted an RCT that compared real-time ultrasound-guided spinal anesthesia with a pre-procedural ultrasound-assisted approach in elderly patients undergoing hip fracture surgery. All procedures were done by one of 3 experienced anesthesiologists. Now, this group has done quite a lot of work with ultrasound-guided neuraxial blocks, and one of the interesting things about this paper is that they describe and use 3 different approaches to their real-time ultrasound-guided spinal anesthetics. The first is similar to the real-time thoracic epidural insertion I discussed earlier, in that a PSO view is obtained and the chosen interspace is positioned close to the edge of the screen. The needle is then inserted in plane in a caudal to cranial direction as shown. In the second, the PSO view is again obtained, but this time the chosen interspace is placed in the center of the screen, and then the needle is inserted on the medial side of the probe close to the midline and inserted out of plane with a minimal lateral to medial angle. And this basically mimics the landmark-guided paraspinous approach we've been discussing. The third one, which I think is pretty innovative, and which they have previously described elsewhere, is to use a transverse view of the interspace and anterior complex. The probe, however, is shifted to bring the edge of that probe close to the midline so that the needle can be inserted in plane at a steep 10 to 15 degrees lateral to medial angle to enter the space, again mimicking the usual angles that we might use with a conventional landmark-guided paramedian approach. However, what they observed was that the real-time ultrasound-guided approach was significantly more difficult than the ultrasound-assisted approach. More needle insertion attempts and passes were needed, and the first skin insertion and first pass success rates were significantly lower. It also took a longer time to complete the real-time ultrasound-guided spinal, and the anesthesiologist rated it as a harder technique to perform. Furthermore, in 8 out of 57 or 14% of the real-time ultrasound-guided patients, they were unable to obtain CSF backflow, and they had to cross over to the ultrasound-assisted approach, which was subsequently successful. These findings somewhat vindicate my personal opinion about real-time ultrasound-guided spinal anesthesia. I confess that I still struggle to find a place for it in my practice. It's definitely a more complex and complicated procedure, and I don't think it's necessary in most patients. In those patients where I really need it, which is mainly those with very narrow spaces or the obese patient with deep spaces, I can't image the spine windows well enough, nor can I image the needle well enough to guide it accurately into place. I think all of us know how difficult it can be to visualize an in-plane needle, especially at large depths and with steep angles. In addition, as I've often said with obese patients, you have to use 2 hands to control the skin and advance the needle to make it go in a straight line, especially if it's a long needle. Though you could get someone else to hold the probe, but that isn't always feasible. To be fair though, there are studies that support real-time ultrasound-guided neuraxial blocks, including this one, but they are all generally in Asian patient populations where the spectrum of body habitus is perhaps more favorable. For now, I personally find that in my practice, I have the best success with pre-procedural marking and then just focusing on my needle handling and the tactile feedback, rather than trying to juggle both probe and needle. I'm going to end with one more interesting paper which provides a final tip to consider when using a paraspinous approach in the lateral position. Zhang and colleagues performed spinal anesthesia in 90 elderly patients who were undergoing hip fracture surgery, and again all were experienced practitioners. The patients were placed in a lateral position, but in half of them, the chest and shoulders were raised by 30 degrees, what they called an elevated lateral position. And what this does is it attempts to create a lateral curve of the spine to widen the paramedian interlaminar spaces on the dependent side. And as an aside, if we look at biomechanical studies on the amount of mobility in the spine with lateral flexion, this would seem to be more effective in the thoracic rather than the lumbar spine, and so perhaps this strategy is something to consider investigating in thoracic epidurals. But returning to the study, they assessed and marked the interlaminar spaces with ultrasound, and although there was no significant difference in the quality of PSO scans, it wasn't powered for this. And you could argue that there is perhaps a trend to better views with the flexion. Most importantly, however, they found that this elevated position was associated with reduced technical difficulty based on several metrics of needle insertion and redirections. Patients also reported lower discomfort scores for the whole procedure. Since reading this paper, I've had the chance to try it out once myself in a hip fracture patient. I elevated the head of the bed as shown, and I made no attempt to forward flex their lumbar spine or legs so as to improve patient comfort. The spinal was very easy to perform, and so I have to say that it does look like a promising strategy, and it's one that I will probably keep experimenting with. In conclusion, I do think that the paraspinous approach deserves a lot more attention. Until only a few years ago, it was something that I neglected and even avoided for many of the same reasons that you probably do. But I've since found it a very useful technique that solves many difficult neuraxial blocks in my practice. And I think it's great that it's potentially better for our patients, being associated with less back pain and a lower risk of post-dural puncture headache. But like all skills, if you want to use it effectively, it requires that we understand the proper technique and the principles involved, and that we invest a decent amount of practice to become truly expert. I personally make sure that I go out of my way to keep doing it and to improve my own competence. There is no doubt that ultrasound scanning is helpful. I prefer pre-procedural scanning and marking, but again, I note that my technique is somewhat different from that described in most papers, and you'll have to figure out which one works for you, especially in the truly challenging patients. At this time, I continue to have my doubts about the utility of real-time ultrasound-guided neuraxial blocks, but I would encourage further exploration, especially in difficult thoracic epidurals.